Hello guys, we will discuss about dementias. In dementias, I will discuss today about FTD, that is Fronto Temporal Dementia. Afterwards, we will discuss about all other type of dementias like Alzheimer's, vascular dementia, etc. So it's common between 5th to 6th decade. Then family history is common in the FTDs, and it is AD, means autosomal dominant in only 10 to 20%. And in FTDs, frontotemporal dementias, three variants will be there, and they are BV FTD, means behavioral variant FTD. Second is semantic FTD. Third is non-fluent or agrammatic FTD. Then coming to what are the clinical features in it, most common is behavioral variant FTD. Because of loss of social and emotional circuit dysfunction, the patient have manifestations like apathy, disinhibition, compulsion, loss of empathy, compulsions, loss of empathy, and overeating. So apathy, disinhibition, loss of compassion, loss of overeating, etc. Often, but not all of them, have executive control difficulties or executive dysfunction. So then coming to semantic variant clinical features, patient slowly loses the ability to decode words, then objects, then person specific, then emotional meaning. So you can't decode words, object, persons, emotional meaning. Then coming to non-fluent or agrammatic variant. In this, there is profound inability to produce words. They can't produce words, often with motor speech impairment. So in semantic, the patient won't understand the word, object, or person or emotion. In non-fluent, they can't speak or they can't produce word. And then coming to what are the structures involved in different things, like in behavior variant what are the structures involved, in semantic what are the structures involved, and non-fluent what are the structures involved. In behavior variant type, anterior cingulate gyrus, frontal insular atrophy, then orbital and dorsolateral prefrontal cortex atrophy. So anterior cingulate, frontal insular atrophy, orbital or dorsolateral prefrontal cortex atrophy. These will be seen. Then in semantic variant, we can see the atrophy of left anterior temporal lobe atrophy. Semantic law, left anterior temporal lobe atrophy. Then coming to non-fluent or agrammatic type. In this, left or dominant frontal operculum, dorsal insula, and precentral gyrus. Now you can see the images in this. First, in behavioral variant, I am marking behavioral variant, first one in the image. You can see that pink color one, they are atrophy of cingulate gyrus and frontal insular cortex and orbital. Then the red one is left anterior temporal lobe atrophy. Then the other features include cholinergic system is spared so and hence anticholinesterase inhibitors won't be helpful in these patients. Then parietal lobe functions like visuospatial and arithmetic or arithmetic, like mathematical calculations, may remain normal until late stage of FTD, because only frontal and temporal are involved. So parietal lobe function is spared. Then coming to genetics, C9ORF72, that is open reading frame ORF. This is the most common cause for FTDs. It includes hexanucleotide. Then other ones are mapped MAPT and GRN. That GRN, MAPT, then MAPT codes for tau molecules, GRN code for progranulin. Then coming to neuropathology, the hallmark is, as the name says, frontotemporal dementia. So frontal cortex and temporal cortex are involved. Then along with that, insular cortex also involved. So hallmark is frontal, insular, and temporal cortex involvement. So frontal, insular, temporal, and then coming to pathogenesis. What is the pathogenesis? Mostly because of misfolding of tau proteins. Now increasingly believed that this may be due to prion-like properties of the proteins. And coming to treatment, it is just symptomatic. There is no available treatment as of now.